almost done. My name is April Morris. I'm a nurse practitioner. I was in liver disease or hepatology for about 16 years, and then I made the switch over to endocrinology for the last couple years. So we're going to talk today about the treatment of the metabolic syndrome and what is our role? What are our NP and PA role in managing and the other medical issues that can also improve MASH. And so I have no relevant financial relationships to disclose. And so the four objectives I really want to kind of touch on are, identifying our role. What do we do? How can we help manage, metabolic disease, weight loss medication options? We've touched on those a little bit, which have been great, going into the GLP-1s and different things. Considerations for using available weight loss medications. Not everybody can use everything. And so kind of going through that as you look at your patient and making sure that they're safe to start some of the newer medications, or maybe look at some of the older medications instead. And then the treatment review of other metabolic disorders, that will be very quick because I have 15 minutes and there's a lot to unpack. So I will focus more on obesity because that is the major issue, right? Nationally and globally. So we really need to kind of focus on that, and it really does help everything else. And so the approach and what we should really help facilitate is a multidisciplinary approach. It's not just hepatology or GI, it's not just endocrinology, it's all specialties, including in addition, or really starting with primary care, but everybody, even bariatric surgery. This is going to be the most successful and best approach to tailor for each patient that comes through our door. Looking at them as a whole person and not just their liver, or for me, not just diabetes control. And so open communication is so important, making sure that we're able to Teams or IM or send a note to their other specialty, other specialists to make sure that we are talking to each other so that we can effectively and successfully manage that patient. Reviewing medication lists. This is a huge thing. So we have patients in front of us that I deal with veterans at the Richmond VA, and they've been on medications for a very long time. And a lot of times they're sometimes not updated. And so looking at their medication list can be helpful because they may be on obesogenic medications, things that promote weight gain and are really already starting behind. And so there are newer medications out there that are more neutral or even help promote weight loss. So we have to look at that. Offering recommendations, there's a problem. Let's help with a solution, right? Not just say you need to get them off that glipizide right now. What are you thinking? No, let's do this instead of that, And so being able to maybe recommend, not to overstep, but recommend maybe this could be a better option for them. And then reviewing control of comorbidities, making sure that we're looking at the blood pressure that's done every time they come through the door. Blood pressure's done, kind of look and see what their pattern is. Are they 145 over 95 all the time or around that range? We need to kind of address that if they've been diagnosed with hypertension. We can do that as NPs and PAs. We've been taught how to do that. So, and so then also looking at hyperlipidemia, making sure diabetes is well controlled. If it's not, making sure to refer out to the right people like myself and making sure that they're well controlled. And so this is a one snapshot, one page thing I have in front of me at my desk that I look at because there are a lot of medications out there. And on the red on the left, those are the weight gaining or weight, what do you call it, obesogenic or weight gaining medications. You can see it's very small. If you email me, I'm happy to send you a copy of this because it is very helpful to look at all classes, including diabetes. Insulin, number one, insulin causes weight gain. And so there's new medications out there that are better. Of course, antidepressants, we know they can cause weight gain. Depot shot, if they're getting, for contraception. There's a lot of different things. That IUD is a better option. There's a lot of newer medication out there, if they have access to it, that actually can help promote weight loss or at least weight neutral so that we're not kind of setting them up to not be able to lose weight. And so this is very helpful for me in my practice. I have it and I can email you a copy of the nice, pretty colors and all that if you just let me know. And so I am going to focus a little bit on weight loss options. These are the kind of the current options. There's a lot out there. These are the ones that we typically, or my colleagues and myself will use. Phentermine topiramate, which is Qsymia, GLP-1. Obviously, we've talked a lot about that. That is the shiny drug that everybody wants in national shortage and hard to get for obesity, but can get for diabetes. But then we can't get it because Hollywood wants it, and it's just been a whole thing the last 2 years. So, and then bupropion and naltrexone. Naltrexone now is a national shortage, but that's Contrave. A bit of a pill burden, but topiramate and orlistat, we'll kind of touch on that a little bit. Yeah, it's an oldie. It's a real oldie. So considerations, like why would we not give that nice shiny GLP-1 to everybody because it's so effective? And you have to look at, number one, what can you get? We have a formulary, and insurance companies have formularies, and sometimes they won't let you get that. So it's good to consider other options, but also making sure that that's the right patient for that option. And so this is just a little synopsis, a little list of things that you have to consider. One thing I want to highlight is that for diabetes, all of these medications improve diabetes control. And so you can't go wrong, but it's all about looking at what's going to be best for that patient. Cardiovascular disease is something to consider, hypertension, seizure disorder. You have to look at to see, okay, is this patient going to stop right away or immediately? That could be a problem, or can increase your risk of seizure with bupropion and naltrexone. So you do want to think of those things and see what else they're taking. One thing I do want to highlight, and the only reason why we use orlistat is depression. If they have recurrent or major depressive disorder, they may, or suicidal attempts, suicidal thoughts. I deal with veterans. And people, our population in general, they have serious depression. You may want to, they may only be eligible for orlistat. And so that's something is better than nothing type mentality. And you could, maybe consider that. But you do want to make sure that you're aware of their medical history. And so just really quickly, just touching on each of these, phentermine topiramate, the side effects, average weight loss over a year is about 10%. Phentermine is one of those things that's really indicated for a short term. Rapid heart rate is an issue with that, but also it's the cheapest without insurance. And so phentermine is still around because it does work. And it also is affordable if insurance doesn't pay for weight loss. And I want to go back, you don't want to use phentermine in those cardiovascular patients. You do want to be careful of that. And so bupropion and naltrexone or Contrave, mentioning naltrexone is a national shortage, so it may be difficult to get, but there are some side effects to that as well. About a 5% body weight loss. However, if there's intense diet and lifestyle, like with everything, you can actually have better success with 10 to 15% if you follow Jonathan's, plan that he laid out for us, and making sure not the HIIT, but do the resistance and aerobic training. And, I always call it the trifecta. You got to do the diet, you got to do the exercise, and then you can do the medication, of whatever is available, but you just can't do one without the rest, so it is effective. And so GLP-1s, we know the GI symptoms for our patients. Usually it's more constipation, but they can get a little bit of bloating, nausea, even some diarrhea, headache, fatigue, dizziness. There is as we saw with the previous presentation by Robin, 10 to 15%, and maybe Jonathan too, 10 to 15% body weight loss, weight loss. So it is very effective. It's a wonderful medication. It's great. If we could put everybody on it that will qualify for it, we absolutely would, because it is very effective. You have to be careful about gastroparesis and pancreatitis in patients, and also medullary thyroid cancer family history. So it's not, you do want to ask those questions to make sure, but you're right. Who should be managing? If you know how to do it and you're qualified, do it. If you can get it, and it's no competition here. Just make sure you do it right is what I go by. And if you can get it approved. Topiramate, this is one that I do use, and it is effective. It does work. One thing people will complain about is metallic taste. I had one patient tell me, I like my Dr. Pepper. My Dr. Pepper doesn't taste right. I'm like, great, drink water. I'm fine with that. You don't need to drink it anyway. So I'm happy with that. Things taste funny and you don't eat it or drink it. So, but it does. Sometimes it works, sometimes it doesn't, but it's pretty effective. About 5 to 8% weight loss with this. Orlistat, as I mentioned, the real reason we use Orlistat is really for those, significant patients with depression, and it's an option. GI folks may not. It's a lot of GI issues, so GI folks are like, very little weight loss, and is it worth it for the oily stools? Because it blocks the absorption of fat, dietary fat, and so in the stomach and small intestines, and so the stools come out oily, diarrhea, abdominal pain, flatulence, all those things. That kind of is more GI. You get wonder if it's risk benefit because a lot of GI issues, but very little weight loss. But it's something to offer patients if there's no other option. And so hypertension, not much has changed. You do, if they are diagnosed with hypertension, you do want to make sure that it's they remain and kind of keep them less than 130/80. That does reduce their cardiovascular risk or events. And first line therapy is listed here. You do consider if they're African American, they have chronic kidney disease, sort of, which one is going to be best. Single pill combination is a good first line strategy. Here's the algorithm. Again, this is something that's out there. You will see lifestyle intervention, non-pharmacologic, where, diet and exercise is still going to be something that's important to, kind of touch on every time, you see your patients. Hyperlipidemia. So this is just looking at the risk, CVD risk, by the calculation that we'll do. And it's a 10-year risk. It is an easy thing to pull up. A lot of times you can find in the lab sort of everything that's necessary. Diabetes is considered, we consider it a vascular disease. It is a part of, cardiovascular disease. So you want to see if they're at low risk, great, lifestyle modification. If they're at high risk, greater than 20%, you definitely want to introduce drug therapy along with lifestyle intervention. In the middle, it gets a little gray. So you may want to consider doing a CAC score every 5 to 7 years just to see where they are. And if it's, it's based on age and artery narrowing and different things, and see sort of how aggressive you should be with that patient. And always, I cannot say it enough, you always want to get patients' family history. Yes, they inherit in their genes certain things, but they also inherit diet, their diet. So, but you also truly, if they're early, 40s having heart attacks or strokes and stuff, you do want to ask those questions to see and consider doing a heart CT. And so here are the guidelines. The main thing, statins are still first line. It hasn't gone away. Statins are safe overall. Statins are one of the most prescribed medications in America. So a lot of people use statins. If they're diabetic, we put them on statins. It's not anything that's foreign. Atorvastatin, rosuvastatin is great. Be careful with rosuvastatin if they have end-stage renal disease. But that is the high-intensity statin. That's great to lower that LDL greater than 50%. And so type 2 diabetes, again, pre-diabetes, as we know, is 5.7 to 6.4. Diabetes is diagnosed when they're greater than 6.5%. First line therapy, still metformin. You want to put that when they are pretty much in the pre-diabetes stage. Go ahead and put them on metformin, and go ahead and start that. I will tell you, it's many reasons, of course, because you want to treat their pre-diabetes so they don't progress to diabetes. But also a lot of times with formulary, you have to do metformin first. So if they do not tolerate it, go ahead and start it and find that out. And then, a lot of times to get the GLP-1s or the empagliflozin and some of the newer medications, they do require you to kind of try some of these things out. So it's good to go ahead and don't hesitate to either refer out, get with primary care, or go ahead and put them on metformin if it's safe from a liver perspective or standpoint. And lifestyle modifications always is going to be, this is going to be important. I wanted to include this slide just so you have it, but it's very busy. But one thing I will point out with this slide is that GLP-1s are everywhere except for the far right where it comes to cost. The cost is when you get the weight gaining medications, things like pioglitazone that we talked about just a little while ago, things like the glipizide, glimepiride, all those cheaper medications are weight gaining. And so, but if they need to be on something, and also insulin, something is better than nothing when it comes to diabetes. So you do have to look at the risk versus benefit, and get them on something. So this algorithm, of course, course, lifestyle, that you'll see that the newer medications are still definitely sort of the medications of choice. So take home points. I have 8 seconds left. The APP role in treating metabolic disease should be collaborative with other specialties. For best management, medication review is important. You'll be surprised of how many things can cause weight gain. Multiple weight loss options are available, but you want to make sure you know some of the limitations and consider certain medications over others with each patient. Lifestyle modification should always be discussed with medication intervention. Always talk about food. I'm a food person. I talk about food all the time. I tell people stop drinking liquid sugar, stop, eating the, certain things. There's no Cheeto tree, Dorito tree, eat real food, just make sure you have that conversation. And the APP should monitor control of the metabolic diseases and know when to refer. We are here for you all. Refer to us, refer to primary care, refer to everybody you can to get that patient on track. Thank you very much.